Jar Oil. The company have filling stations across the country, and our rates are relatively cheaper than anyone else across the country. Jar Oil is the biggest producer and distributor of cement in the country with the most competitive prices in the market.
Excellent jam, Wave.
Yo, apply. Yo, luta do dede. Luta mo nulo jël moto nga andil ma xaalis. Hello?
Bisul mu fine.
What?
Bisul mu fine.
Oh, yes!
Wave acts in Gambia. Deposit and withdraw money, pay bills, and buy mobile credit without fees. Transfer money wherever in the country for only 1% fee. At Wave, Bisul mu fine. Wave, your money is yours.
You're with Coffee Time on West Coast Radio with me, Peter Gomez. Thanks for joining us, and we thank our sponsors especially. Joining us now are two of the country's most respected medical minds, a consultant neonatologist and a pediatric surgeon. They'll share stories from the front line of newborn care, reveal what it takes to operate on the smallest patients, and time permitting, answer your burning questions about child health. So if you're a parent, a caregiver, or simply someone who cares about the future of our children, stay with me and Coffee Time. This is one conversation you don't want to miss. And let's start with the basics, the introductions. And since they say ladies first, let's go first with the lady.
Okay. Good morning, listeners. My name is Professor Gosta Eneh. I'm a professor of pediatrics and a consultant neonatologist. I work at Edward Francis Small Teaching Hospital. I'm in charge of the neonatal intensive care units.
Fantastic.
Thank you.
All right. And after ladies, of course, men.
Thank you, Peter, for having me. I am Dr. Cherno S. Jallow. I'm a consultant pediatric surgeon who is responsible for operating neonates from birth to some jurisdiction 21 years. And then I just handed over as head of department of surgery. And I'm also currently doubling down as the deputy chief medical director of Edward Francis Small Teaching Hospital.
Fantastic.
Thank you.
You're both welcome. So let's start with your roles and what you do daily. Dr. Augusta Eneh first.
Okay. Thank you very much. Well, taking care of the newborn is very demanding. You need special grace for that. So my role there as the consultant in charge, as the head of the unit, and I'm also the head of pediatrics, Department of Pediatrics. So every morning we have what we call a review. We review all the patients, babies that we admitted during the call from the previous day. It's a whole department that takes part in that. So we look at the cases, see what the areas we did well, and look at the gaps and the way forward. That's how we start our day in the department. Everybody takes part. After that, for me, I will just briefly do some administrative work as the head of department, then go to the newborn units, where depending on the day, I'll do my ward round, seeing all the babies that were admitted with my team. We have senior registrars, the nursing care is very important for the newborn. So we go around seeing those babies. They are very ill babies, critical ill babies. By the time we finish, maybe 4 o'clock. At the end of that, we have finished, but we have not finished for the day. Since I'm the only neonatologist, it means I'm on call every day. So even when work officially has ended by 4, my work has not ended. Even if I go home, I'm still being called when need be, and I keep in touch with the team. So that's how the day goes.
So throughout the Gambia, you're the only neonatologist.
Yes.
Oh, wow.
Yes. And neonatologist means taking care of babies from birth to at least 28 days of life.
All right. Thanks for being here.
Thank you.
Out here in the Gambia. Dr. Jallow, what's your typical day like?
It's not different from Prof. Eneh. The only thing is, for us, we have to be on the ground. Meaning that you have to come to be in the theater. So mine is just like hers, very intense. From 5 a.m. Doing the reviews and other things, and then doing administrative work till 9. Then just move into clinical activities, and then I am there. There is no time bound. Sometimes you are home and you are called, you operate sometimes the whole night, you are in and out. But thank God, now I have 3 strong Gambian senior registrars. Senior registrars means specialist. One of them will complete his training as a consultant pediatric surgeon next year. By God's grace, because I was alone, just like Prof. Eneh, taking care of all the surgical problems of children in this country. But next year we'll have one who's coming out, then another one is also in the offing, and another one has just joined us. So the objective is to quadruple ourselves within 4 or 5 years. By God's grace, Gambia will start having their own pediatric surgeons, which EFST is working very hard to create them.
Good luck.
Yeah.
So what inspired you to specialize in neonatology?
I would say really compassion for the newborn. It's like giving you keys to a tiny, precious kingdom where every small victory feels like a huge triumph. Then the resilience of the newborns and the impact their care has for the family. Every day is new challenge in newborn. And new challenge means you have to be on your toes. And at the end, you see this tiny baby struggling. It gives one strength. Then it's good to be part of their first chapter in life. And after so many years, you see these tiny things that you have worked hard, and they see you on the road and call you and say, their parents will follow you and say, this was the tiny baby you took care of. So it gives joy to see, and the joy these parents have, because when they have newborns on admission, it's stress for them.
Of course.
Yes.
Of course.
Thank you.
Dr. Jallow, what inspired you to become a pediatric surgeon?
Knowing that there has never been, that's known, and then there was no pediatric surgeon before, and then seeing the problems of children in this country, majority of which leave this country, the ones that cannot live would perish on the ground, and then the adults, these other surgeons we have, they really have to be commended because they kept the fort for us until we came, and so most of the kids leave this country, and then it was costing the country millions of dollars, and then a lot of lives has been lost. So, but during my internship, seeing the problem, and then inspired me to say I must do something on this. So after doing my specialist training as a general surgeon, then I subspecialized, coming out as one of the first Gambian pediatric surgeon. Now I can comfortably tell you that the referral outside this country are significantly reduced. Of course, it will never be zero, even if you have the best facilities. And then we've operated over 1,200 kids, and then all type of surgeries you think of on the children we've done. And then if we are not able to do because of equipment, we tell our collaborators to bring, we do them on the ground. And then by the way, 2019, EFST was the best case, got the award at the British Association of Pediatric Surgeons as the best case report, because we managed a child who has penile amputation, and then we got experts to come. We did the penile reconstruction here in the Gambia, from opening the chest, solving very emergent things on children. We've done all of that in this country, in EFSTH. But I must tell you, all of these things happen at the backdrop of hardworking people like Prof. Eneh, who takes care of my kids. After my surgeries, we all work together as a team, and then also a dedicated team like the residents who are there currently, and then they will come up to take some of those responsibilities. Because of all of these things, I'm able to give some of my time to the teaching hospital as a deputy chief, to make sure the hospital also attain the standard that is required for any teaching hospital in the globe.
And Dr. Eneh, what are some of the most common complications you see in newborns here in the Gambia?
The common ones are perinatal asphyxia. Then, neonatal jaundice.
Is there a layman's name for that?
Yes, I will explain. Okay. Neonatal jaundice and sepsis infection. Perinatal asphyxia comes about when a baby is born and did not cry immediately after birth. Oh, wow. That first minute is the golden minute. Whatever happens in that golden minute affects the baby. So when they have not taken enough oxygen, because that cry makes them to take oxygen, and that oxygen stimulates the brain, then the heart, everywhere. So when that does not happen, it affects the baby, and the outcome is usually poor. It affects their brain. They become mentally retarded. They are not able to help themselves. And so many things. Some of them may survive, but the death rate is usually high. Those who survive, what's the quality of the survivor? That it's not just enough to survive. When they survive, they have cerebral palsy. They can't help themselves, and it's a lot for the parents. The parents all through their life, that baby is dependent. Even if it becomes 12 years, you see the parents still carrying them and all that. Then for jaundice, neonatal jaundice is another common thing we found out, which is the yellowness of the eyes, the skin, and it also damages the brain. And action should be taken immediately. For some time now, we have had a lot of them, a lot of babies, and unfortunately, they come late. And when they come late, it has crossed the brain-blood barrier and damaged their brain. So whatever you're doing, you're just trying to limit further damage. So, and then it's usually good if they come early. If they come early, it can be treated. The interventions, fortunately, we have some phototherapy, which the hospital management, the AFSA, had given us recently some expensive phototherapy unit, the Firefly. They are very expensive, but they are very effective. Before maybe 2 months, 3 months ago, we didn't have that, although we had some other phototherapy unit, but they're not so effective because we had a lot of them. So we kept on doing blood transfusion. You know what it means? You remove the baby's blood, you put the adult blood. It's a lot of work. But by then, before you do exchange blood transfusion, it's so high that the brain has been damaged. So you're just trying to limit more damage. And another thing is infection. These are the three things: infection, then preterm babies. If we talk about the prematurity, the rate is so high in this Gambia. Prematurity, there are so many things that can cause prematurity. We are not here, especially hypertension. A lot of women, yes, hypertension, both in pregnancy or even pre-pregnancy hypertension. So these are the common things we have. Congenital malformation, sorry, I forgot that. It's also on the high. More than I had seen in Nigeria, where I'm coming from.
What malformation?
Congenital. That's the newborn, born with, malformations. A lot.
Okay.
Yes.
Okay. And how has neonatal care evolved in recent years, especially for premature babies? You just mentioned that, and low birth weight babies.
It has actually, technology has helped a lot. Now, we have so many equipment we can use to care for them. We have monitors because they need to be monitored. Like I said, the nursing care is very, very important. So we work hand in hand with the nurses. We have to monitor their heart rate, monitor their blood pressure, monitor oxygen, monitor their respiratory rates. So a lot of monitoring goes on. So technology has helped because we have monitors. Then we have incubators because they cannot control their temperature. You want them to be in an environment like in the womb. So our incubator has helped. Then we have what we call CPAP, continuous positive airway pressure, which helps them, especially those tiny ones that they have not matured, their lungs have not matured. It helps to keep their lungs open and gives them constant, help them in breathing. There are so many other things like this phototherapy I talked about is also technology. Then to even do their tests, technology has helped. Then minimal invasive surgery, which my colleague here is part of what technology has done. If I stay here, we may not finish talking about, but technology has done a lot in neonatal care.
Let's bring in Dr. Jallow. What types of surgeries are more common in babies and how do they differ from adult procedures?
There's something that we always say, Uncle Peter. We always say children are not small adults. So sometimes it's very easy to look at a child and then you think of the adult, you just, you think they are all the same. They are totally different, completely different. Their mechanics, everything is different. So meaning that you need special services, special activities to take care of those children. That's where Prof. Eneh is coming from. So if we spend talking about it, we'll spend the whole day. We'll spend the whole day talking about this. We'll not finish. Okay. So pediatric surgery, as I told you, it depends on jurisdiction to jurisdiction. Some up to 21 years, some 18. But for us, because we are increasing maybe with time, in collaboration with our pediatrician, will increase the age, maybe to 15, 16. But currently, we are seeing up to 14 years. And then now, one of the commonest cases we see are groin swelling. We call it hernia. It's an urgent case. If you see any groin swelling on your child, especially if your child cries around the groin, you see it bulges, please come. It's urgent. If you don't do anything about it, the intestine may be trapped there, and then it may be devastating for the baby. Another thing we call intussusception. In fact, within the last 2 weeks, we saw about 3 where we operated all of them. Two of them we had to cut the part of the intestine that was not good and connect the other part. Thank God they all went home. But the problem we have here is almost all of them present very late. There are signs. I know this program is beyond that scope. There are signs that probably in the future we'll discuss about all of that. So we have that as an emergency that's affecting our babies. And then the congenital malformations she talked about, that they have plenty of that. So most of that will fall on us. We'll send them to theater and help them. Imagine a baby is born and then the intestines are not connected. So anything the child feeds will not go down. And then that one, without surgery, that one obviously would not survive. And then some are born, their food pipe are not connected, and without surgery will not survive. In fact, before our coming here, some of those cases were 100% mortalities. And then now we have
before. Not
now. Now, in fact, we're doing amazing things. Yeah. So the problem we have in the teaching hospital is difficult. There's a thin line between what is advert and what is telling the public the services you have. So if you delve into what the service you have too much, it may tend to be interpreted as advert, and that's unethical. And then we always want to be very ethical in what we do.
Okay.
There are a lot of amazing things the teaching hospital we're doing. Okay. From opening the chest to the abdomen to having 6 hours, 7 hours surgeries, and then the outcome is really amazing.
Okay. Yeah. You're asking parents whose children may have swelling around their groin, to contact you immediately. So what goes into preparing a child and their parents, their family, for surgery?
It's a multidisciplinary thing. Not one person can do. And then the parents are very central in this whole thing. But one thing we always echo is to dignify parents and then the kids and give them maximum respect. And then work with them to support the child, because after the surgery, that child will go back to them. Because most of them, for example, this interception, by the time they come to us, they would have vomited, they would have lost a lot of water, they would have lost a lot of things we call electrolytes in the blood. So if you rush those ones to theater, what would happen? You may lose them on table or immediately after operation. So that we will spend time giving them those fluids, those electrolytes. Then we need lab support. But thank God the teaching hospital is doing a lot of things in lab support. Currently, the lab is very much functional because of some partnership we have. I think Dr. Pt.1, when he was here, he mentioned that. So that we will do the labs, and then we will do a full blood count. We check the electrolytes. If they are fine, we will get bloods. So that when the child bleeds too much, we may give that, we call it grouping. We'll ask parents to donate. By the way, blood is not manufactured. It's from us, so we should all endeavor to be donating. So then those bloods that are donated, those are the ones that will be given to them. And then now surgery, our theater is child friendly. That is still a big struggle. And then we are working very hard to have a dedicated pediatric surgery theater. In fact, we have a partner, Kids OR. They are ready to furnish a whole theater for us. The only thing they don't do is cement and block. If anybody can do cement and block for us, you are welcome. We don't mind giving the name to you.
The first lady can.
No, but health is for everybody. All hands must be on deck. Not only one person can do. So we call every sons and everybody who can. So now then our theater is child friendly. And then we have our anesthesia machine, which are very good. By the way, our hospital now is fully piped. Today, 10 a.m., we will be inaugurating that. It will be handed over to us.
Fully piped for what?
Fully piped for
service?
Oxygen that he's talking about.
Okay.
So now, oxygen, before we move cylinders around, and then there are a lot of issues. We buy oxygen every month. It will cost us about $1.5 million. Now the whole hospital is piped, and in the plant it's there. There are other backups. UNDP plans are also being worked on. That handing over is a grant program we're having today. A lot of millions have been spent from our partners to get that to us. So we have that in our theater. So now the theater is friendly, the environment is good. We have very good anesthetists who put our babies to sleep. There is a lot of training happening in anesthesia. We have training in nurse anesthesia, and then we have doctors, anesthetists. Now, Gambian physician, doctors, anesthetists. Few years ago, if you say these things would be possible, you will say it's a dream.
Absolutely.
And then after surgery, too, the nursing management is fantastic. We have a recovery room. In fact, our anesthesia department now is accredited to train specialists by West African College of Surgeons. So all of these things tells you operating children in this country, pregnant women, or any cohort, it's something that the teaching hospital is ready. But of course, as a developing country, will have challenges. That's why we should always up our game. We should
come
always
to the challenges later.
Think outside the box.
Dr. Eneh, to bring you back in, Dr. Jallow likes the platform. Yeah. What are some of the biggest misconceptions parents have about newborn health?
I will start by saying the first one, I think, from what I've since I came here, is that jaundice. I'm back to jaundice. They think, that jaundice is not a serious medical problem.
They don't think it is serious.
Yeah, yellowness of the eyes. Yes, they don't think. They think it's because it's very common. Although it's common, there's two types. One can be pathological, one can be physiologic. So up to 60 to 80% of newborns, especially premature babies, will have jaundice. So because they have seen many, so they don't take it seriously. But jaundice is is a very serious problem because, as I said, it can damage the brain. So that is one misconception. And they think that putting eye drop, because of the yellowness of the eye, putting eye drop in the eye will clear the jaundice.
It won't.
It won't, definitely. It has some special treatment, like I said, the photo light and the exchange blood, depending on the level. So that is one misconception. Another one is breastfeeding. They think that the breast milk is not enough, especially when the baby is crying after feeding. No, breast milk is enough. Just breast milk. God has made it like that. Even if they are twins can be exclusively breastfed for the first 6 months of life.
Okay.
Yes. So that's one of the... Another misconception is the cord care. They put all sorts of things on the cord, the baby's cord. Yes. So they put herbs and it is very wrong.
What should they do?
They should use, first of all, if it's a clean environment, you don't even need to apply anything. But in this environment, they have to use chlorhexidine or methylated spirits just to clean the cord. Each time they have to do it very often. Each time they change the diaper, they have to clean the cord. So another misconception is infection. Maybe when a child has infection, there are so many ways it can occur. It may be just poor suck, feeding the baby is no longer, but they think maybe the baby is tired, is sleeping, so they don't really bring the babies early to us. So these are a few ones I have noticed here. Yeah.
And for you, pediatric surgeon, Dr. Jallow, what are some of the biggest challenges in your work?
So getting parents to really understand or agree in going through the management with you, because yes, so that's one. And then the other thing is patients coming late to us. So this we work with you and some other partners to support that. But if I should quickly dilate on the jaundice is talking about, it's very important. So the pathological one are the ones that will not resolve if you don't do some things. So some of the problem of that jaundice could be surgical, and I can tell you we've done what we call biliary atresia, about 8 of them. That is the connection between the intestine and the liver. The liver is not there because of that. No bile is going. If you don't do anything, the liver fails by 2 years. So that one is about 7-8 surgery. Is 5 hours. So we've done where you remove all of that, you connect the intestine to that place, and then about 3 or 4 connections we do, and then so jaundice is yellowness of the body is real, and then when parents have it, they should report. But now that we are in a cancer month, some of the misconception it's that when a child's tummy is big and then they feel a tumor, a mass, sometimes they may feel it will resolve, or it's because of devil, or probably they may even go and get treatment from other places. Traditional treatment before they come to us is late. I can tell you, cancer treatment in children has really improved very much. We had a hemato-oncologist who put some programs. He left the country not long ago. And we are doing cancer surgeries, pediatric cancer surgeries from womb's tumor. That's tumor of the kidney is one of the highest. So from those ones to other cancers in children. So if anybody has a child who has those type of things, please, if you come, we should be able to help you to some extent.